as of right now, I'll try to communicate with Dr. Davis. As of right now, let's see if, since the white code, we want you to be there. I mean, there's no about it out there. So as of right now, as I speak tentatively, let's plan on all meeting. Tentatively, I'm saying, I know, inform Dr. Davis, but let's plan on tentatively meeting for laboratory at 1 o'clock next week on Tuesday. Am I making myself clear?
Yes.
I know she scheduled something, I think we're involved, but I'm saying right now as we speak, tentatively, okay, so that's gonna at least free you up for Wednesday. We can't afford to do 2 days, I mean, a whole week, and then the test is deferred next week, so I don't know what these folks are thinking. So tentatively, let's shoot for 1 o'clock on Tuesday. If something changed, hey, we're not here on, but we'll be here Tuesday morning, so if something changed, I either have to put an announcement on Blackboard and let you know Tuesday morning. Can we agree on that for right now?
Yes, sir.
1 o'clock on Tuesday next week, we have one big giant laboratory. That's the plan as of right now.
All right. Put something on Blackboard.
Okay, sports fans. Let's talk about a couple things. Remember in laboratories we learned how to calculate the volume distribution. We said that the volume for this model was equal to, we could just easily calculate it as the dose, which we call A0 divided by C0. I don't have, oh here it is. Divided by the initial concentration. But I said that we would come back and talk about some of the remember this is all related to ADME, absorption, distribution, metabolism, and excretion. So volume here has to do with the distribution of the drug throughout the body. So in the body, there are certain, let me see if I can diagram this. There are certain fluid compartments. Fluids. And I'll just say approximate volume in liters, okay? So you have intracellular fluids, not intracellular, I want to say extracellular first. Extracellular. You have extracellular fluids, and you've heard of these in your physiology and pharmacology class before. But and this is assuming a 70-kilogram person, okay? So you have extracellular fluids, and if I recall correctly, those fluids usually occupy a volume of up to approximately 13 liters. Let me check my notes. 13 to 16 liters is what I have. So the extracellular fluids, the fluids outside, cells, between the cells. So you got extracellular fluids, and then within these extracellular fluids, plasma is an extracellular fluid. So you got plasma, and the plasma volume, according to my notes, is approximately, I'm just going to say approximately 3 liters. I'm fudging, 3 to 4 liters in a 70-kilogram person. And then you also have what's called the interstitial fluids. Now these interstitial fluids are the actual, fluids between the cells. So like in your muscle cells, you got cells. So interstitial fluids is what we normally think of as extracellular fluids that's outside of the cell, okay? So you got plasma, that's one type of cellular fluid, extracellular fluid. And then you got these so-called interstitial, between the cell, interstitial fluids, okay? And those fluids are approximately 10 liters. So that's how they come up with this value here of 13 to 16 liters. So the plasma and interstitial fluids make up the extracellular fluids. That makes sense so far? So in a 70-kilogram person, the extracellular fluids will occupy a volume of approximately somewhere between 13 to 16 liters. Remember in class now, the other day we talked about the cord-out individual. Because when we get through all these fluids, they're going to come up to close to somewhere between 42 to 46 liters for a normal 70-kilogram person. So then we have these also intracellular fluids. You already know intracellular fluids are. The intracellular fluids, intracellular. And the reason I'm showing you these fluids because, in kinetics, we got this volume of distribution, which I said can far exceed these fluid volumes. So at least if you know what these physiological volumes are, if you get a volume of distribution, then you can assess that volume of distribution relative to these volumes. And the idea is to hopefully give us an idea, okay, is that drug primarily extracellular fluids, we already, I hope you can see here, that if a drug has a volume distribution of 25 liters, it's probably going to have exceeded the volume of the extracellular fluid, so it's going to be flowing over 9 to the intracellular fluids. Presumably, the extracellular fluids, drug will get there first, okay? So we'll talk about that a little bit more in a minute here. So the intracellular fluid volume, in my notes I have, is somewhere between 25 to 28 liters. 25 to 28 liters. Okay. 25 to 28 liters. Okay. So that's so what I'm saying is that's on top of the 16. So for instance, if a drug filled up the extracellular fluid, and these are just guidelines, don't take this as gospel. So if a drug, filled up all the extracellular fluids, then there's an extra 25 to 28 liters that's comprised of intracellular fluids. So if a drug had a volume distribution of 18 liters, we would suspect that it's probably filled up most extracellular fluid. And if it's, 22? So the overflow would start filling up this extra 25 to 28 liters. Does that make sense? Yeah. Okay. Because the body is one continuous whole well. So we got approximately 25 to 28 liters designated for intracellular fluids. Okay. And you know what intracellular fluid is? That's the fluid inside of the cells or whatever. So presumably the drug would, as a guideline, get into the extracellular fluid space. That's not entirely true. There's some binding protein, but again, these are just guidelines. So generally, if the drug had a volume distribution of 12 liters, it would probably be mostly in the extracellular fluids, because it's 13 to 16 liters that's designated for extracellular fluids. So if this volume is only 12 liters, that's not to say none of it would be in the intracellular fluid, but probably most of it would be in the extracellular fluid if they had a volume of 12 liters. Does that make sense what I'm saying? Okay. And then we have these so-called transcellular fluids. And until recently, I'm like, what in the hell is a transcellular fluid? But, we got fluids, just as examples, we got fluids in the, we got cerebral spinal fluid, for instance. That's a cerebrospinal fluid, in our central nervous system. That's a transcellular fluid. I can't think of the word. I don't want to say pericardium, but pleural. That's what in the pleural space. We got fluids in our chest and abdominal canal. Those are examples of. I'll just say e.g. the pleural space. We got fluids here, cerebrospinal fluid. We got fluids in our kneecap and stuff. Those types of fluids would be referred to as the so-called transcellular fluids. Okay, pleural, cerebrospinal, cerebral. I'll try not to go any lower than this because I know the folks in the back it's hard to see. Cerebrospinal fluids. These are just examples. Okay. And that transcellular fluid occupies a volume of approximately 0.7 to 2 liters. And if a drug crosses the blood-brain barrier, just as an example, it's probably going to end up in the cerebrospinal fluid. So that has a volume too. So the bottom line, based on my notes here, if we add all of these together, this one, and then plus this one, and then plus this here, we get a total body water, a total fluids. I'm just going to call it total body water. What did it say total fluids? Total body fluids. Total body fluids. And I'm writing lower than I plan to, so I'll make sure that I read this to the folks in the back so you know what I'm writing. Total body fluids And in my notes, I think I said approximately 40 to 46 liters. 40 to 46 liters. So remember the other day you heard in other courses where a lot of times they don't explain what's going on, that the total body water, whatever, is approximately 42 liters, 60% of the 70, and I told you that the other day. That's the breakdown. That's the breakdown. So the total would be approximately 40 to 46 liters. So it's going to depend on the person's makeup and stuff like that. So that's why, we got ranges here. Some folks might fall outside of that range. Okay? So I just generally say, you can probably hear most of the time, 60% of the body weight is water. So 0.6 times 70 gives us the 42. Does that make sense? So that's how they come up with that number. But now the thing is, now if the drug had a volume of distribution of 50 liters, of course, it would have exceeded extracellular space. So a lot of that drug would be over here in the extra 25 to 28 liters. Okay. So if a drug had a volume distribution of 50 liters, we would expect that if this is 16 liters, and I got all the way up to 28 liters over here, an additional 28 liters, then if it had a volume of 50 something, it would have filled up this space. 16 plus 28 is only 44. So it would even have filled up most of the extracellular space as well. Is everybody follow what I'm saying? So you say, well, what happened to the rest of the drug? Well, the rest of the remember, as you're learning in your therapeutics and pharmacology, the drug, finds its way out of the plasma, whatever, and it gets taken up by other organs and tissues and fluids outside of the body. So if a drug has a volume of distribution of greater than, say, 40 to 46 liters, that means that, hey, it's filled up all of the fluid volume, okay, and it's being sequestered or taken up by, tissues, avidly taken up by tissues and organs and fluids, okay, that's, going to cause it to have a much larger apparent volume of distribution. If the drug could just access these fluid volumes, if that's all it could access, then it couldn't have a volume of greater than 46 liters. But these are fluid volumes. These ain't considering the fact that drugs do bind to muscle tissue. Drugs do bind to fat tissues and get taken up by fat or whatever. So the more the drug gets taken up by tissues, not fluid sports fat, tissues, that's going to make the volume look bigger and bigger. That's going to make this volume look bigger and bigger. But remember, this is an apparent volume. Once we calculate that volume, like we did in the laboratory, like I showed you, that's okay. It's an apparent volume. It has volume unit. We can multiply that volume times concentration, which we're experts at calculating now, and determine the amount of drug in the body. Does that make sense? Remember, these are fluid volumes, but most drugs have access to other organs and tissues outside the fluid. If it could just distribute in fluid, you would never have a drug with a volume greater than 46 liters, because that's basically the amount of fluid in a 70-kilogram person.
So all these numbers are the assumption on the 70-kilogram person?
Yeah, of course, a smaller person, the total body fluid, you would expect would be smaller. A bigger person would have a larger, in my notes, but I'm not gonna worry about you, breaking it down in percentages of body weight. I just want you to have a general idea of, what those approximate volumes are. So you can relate this to the volume distribution. Digoxin has a volume distribution of more than 200 liters. That we use for congestive heart failures and other types of cardiac arrhythmias. So that tells me, man, that digoxin is distributed into organs and tissues that far exceed the volume of these fluids here. Does that make sense? It's highly sequestered in these other organs and tissues outside of the body. Okay. Now another couple of things here. Think of this in terms of the admin system, distribution aspect of the admin system. What effect would, and we talked about this I think in class before, if I decrease protein binding in the plasma, like a drug binds to albuminemia, what effect would that have on the volume of distribution? It would increase because if a patient had hypoalbuminemia, or perhaps if another competing drug like aspirin and warfarin or Coumadin or whatever it is, a drug gets displaced from its protein binding sites, okay, it's going to be in the free form now, so it's going to be able to leave the circulatory system more readily, okay, and the more drug is able to more readily leave the circulatory system, the bigger the volume is going to come. The reverse is also true if a person like in, I think burn victims have an increase in plasma protein. Don't quote me on that. But I think a severely burned person has an increase in blood albumin. So if that burn victim, if that drug binds to albumin and the plasma albumin volume, I mean not volume, but concentration increase, then that's going to cause more drug to be trapped into the circulation, in the systemic circulation. That's going to have the effect of decreasing the volume of distribution. So those principles are just generally true. And I'm just talking about plasma protein binding. You know, drugs do bind to tissues and organs outside of plasma, but usually in your therapies and pharmacology, that might not even get discussed. But if a drug had an increased binding to tissues or organs outside of the plasma, if that increased, that would increase the volume of distribution. If it was taken up, you know, more by a certain tissue or whatever because of some physiological changes or whatever, that would increase the volume. That would be attracting more drug outside of the circulatory system. That would increase its volume. Usually we just talk about plasma proteins because the plasma compartment, or the plasma in the blood, we have ready access to that. You know, we're usually not trying to quantitate tissue binding to drug binding to tissues and stuff. But we know, you know, from holding pharmacology that, you know, a lot of times the active site and stuff like that is, you know, the result of that locking, you know, drugs binding to, you know, receptor sites and all that kind of stuff. So those things happen, okay? Even if it's not bound to receptor site, you know, for instance, a lipophilic drug, I mentioned this before, is going to tend to want to go into lipophilic tissue, okay? So for instance, you give, you know, a skinny person like me a dose, and it's a lipophilic drug, and I don't have that much fat tissue. You give a person that has a lot of body fat that same dose, they're probably going to have a drastically different volume of distribution because most of that drug, if it's a lipophilic drug, it's going to want to go into that adipose tissue that you know what I'm saying? So a lot of it depends not just on the drug, but the patient's body makeup itself, okay? And then, you know, blood flow and all that kind of stuff to the various organs. So these are just kind of guidelines, okay, that we can look at and make some tentative conclusions about how widely distributed the drug is. Now, the smallest volume of distribution that, I think I'm okay. The smallest volume of distribution that a 70 kilogram person would have to be at least the plasma volume. In other words, when I inject the drug into the bloodstream, remember this drug is going into the bloodstream in this model, okay? It's got to at least distribute throughout the plasma. And you know what plasma is versus whole blood, right? You take whole blood and spin it down, centrifuge it, you get the plasma. Well, the drug that I inject into the body, it might not go into the erythrocytes, those are the red blood cells. It might not go into leukocytes. It might not bind to the platelets and all that kind of stuff. But at a minimum, that drug at least has to be dissolved in the plasma. So in a 70 kilogram person, and I can't think of any drugs that have a normal so-called 70 kilogram person that have a volume distribution that small. But this is the smallest theoretical volume distribution that a patient can have. Does that make sense? I don't care how much drug you give, what dose you give, it at least has to distribute through the plasma, even if it don't go into the red blood cells and all that kind of stuff. Okay, so this is the smallest hypothetical or theoretical volume that a person can have is 3 liters. I can't think of a drug with a volume distribution that small, but in theory, that's the smallest one you have. If the volume of distribution was just 3 liters, you would conclude that drug is strictly confined to the plasma. I don't expect to find that drug in the heart or the liver or muscle tissue, whatever the case may be, because if it was in the heart, liver, muscle tissue, then it would have exceeded the plasma volume, and we'd be looking at that drug, you know, in volume greater than 3 liters, okay? It might be part of this volume. In other words, if a drug has a volume distribution of 5 liters or 6 liters, it certainly has exceeded the plasma volume. And if it's only 5 or 6, most of it's still going to be in the extracellular fluid. But if it's only 5 or 6, we don't expect to find much of that drug in the intracellular fluids. Conceptually, does that make sense what we talked about here for the last 10, 12 minutes? 15 minutes? Okay, so volume of distribution, admin, absorption, distribution. We know how to calculate it. We know a little bit more conceptually now about what that volume is actually telling us. what it means when we look at this volume relative to actual physiological or anatomical volume. We can compare the two. We can get, okay, this drug is widely distributed. You look at a volume distribution like for the Johnson, more than 200 liters, you say that drug is widely distributed. It must mean a lot of tissues and organs outside of the bloodstream. Okay? Okay, another concept, so that's volume. Can I erase this? We good? Okay. Well, I can leave it up there for now. Another pharmacokinetic parameter that you're going to be hearing for the first time in discussion of the first time in this course is total body clearance. Total body clearance. And usually in kinetic, but in this course I'm just going to call it CL subscript T, total body clearance. You might also hear this referred to as plasma clearance. For our purposes, they mean the same thing. So if I say plasma clearance or total body clearance, I'm talking about the same concept, okay? And total body clearance, one way of calculating it is the volume of distribution, that's this V right here, that's this apparent volume, times the first order rate constant, KEL. V times KL is an estimate of volume of distribution, not volume, but clearance. So it's going to have units of volume over time, because remember, KEL is reciprocal time. V is in volume units. So this might have units hypothetically of, say, liters per hour. That's one thing you need to know about it, okay? Because, you know, we do need to be cognizant of our units that we already know from laboratory and stuff like that when we do practical problems, you know, what's the units, okay? So anything in kinetics, I shouldn't say anything, but most things that have units of volume over time, usually it's going to be a type of clearance value. So total clearance, we're going to learn another way to calculate it, okay? But one way is volume, this volume that we know how to calculate, times the rate constant, which we know how to calculate. We're rate constant and volume calculating experts now. Did I see a hand right there? Someone?
Would it be L over HR?
Say that again?
Would it be L over HR to the -1?
That could be, yeah. This can be expressed as volume over time, which you probably looked at an old exam or something like that and saw I got tricky or whatever. Of course, that's the same as volume times T to the power reciprocal time. But you don't usually see it like that. You don't usually see it as V to the T to the power -1. But yeah, you know, I've done that kind of stuff on it. You probably got a stack of exams. But you know what, sports fans, I'm joking and having a good time up here now because I'm feeling 100% better. But the thing is, just like I told you a week or so ago, I've always, I encourage students to use. My only problem is that when you use those exams exclusively and you're not doing what you're supposed to, a lot of times, especially in a class like this, it's going to cause problems. In some classes, it ain't going to cause no problem. I was a student for a long time. BS degree in pharmacy and a PhD in pharmaceutical science. My point is that, you know, I know that as a student, sometimes for certain classes, I could just take those exams and that's all I studied and I passed. And I know that some of you all employ that same philosophy in certain classes and it's getting you by. I'm saying, don't try that here. Because yeah, I use old questions, but I always got some new stuff. I'll change some stuff around. So if all you're doing is studying the old exam, or it's the night before, it's Sunday night now, I'm pull out my stack of old exams. That might not get you where you want to go. That's what I'm saying. But use the old exams to fine tune. You know, you're at the free throw line now. You know, you going through your routine. So pull them out. You know, but you've already done all the stuff I've asked you to do. You know, in laboratory, you reviewed your quizzes. You know, you've done the homework. That's what I'm saying.
No, but seriously, when you say
No, I'm just
reciprocal
teasing.
time, does it mean -1?
Yeah, it's reciprocal
Okay.
time, so that's the same thing as V times T to the power of -1.
Okay.
Mathematics, yes. So I can express, but you normally not gonna see it this way. Usually you're just gonna see it based as volume over time.
Okay.
Like liters per hour, liters per minute, or milliliters per hour, whatever the case may be. That's usually the way you're gonna see it expressed. Okay.
So for us in general, do we need to know, like, you know,
They
different
mean the
ways to
same
put
thing.
the.
They mean the same thing. Okay.
Okay.
This and this mean exactly the same thing. Because t to the power minus 1 is just 1 over time. That's what that means. Just like 10 to the power minus 1 is the same thing of 1 over 10. The beauty of math is that it's a perfect science. So if you don't forget something, just put a real number in it. Math is an exact science. So reciprocal time just means 1 over 10. Just like reciprocal 10 to the minus 1 is equal to 1 over 10. Okay. So very good. Good questions though. Good discussion. So that's clearance. Now let me see. This is what I struggle with. One of the things I struggle with. And every time I teach the course, I probably didn't. Well, you guys were with me online, but last fall we were online, and I didn't even try to explain it because I knew I couldn't do it on a computer like I want. But let me just try to give you a better conception of what this clearance is. So let's imagine, and again, if this don't come out right, don't say that the brother didn't try, okay? I don't know how this is gonna turn out. Cause I was thinking of it as I was coming to class today, but I haven't drawn it out. So I'm experimenting with you guys. So we know the math of calculating clearance. Well, let's talk about it, what it actually means. So clearance, by definition, is that volume of plasma that's cleared of drug per unit time, volume over time. Is that volume of plasma? Because for the drug to get out of the body, at least in our model, it's got to go through either metabolism in the liver or the kidney. So both in this model, where we're only showing 2 pathways of elimination, drug excretion and drug metabolism. The drug is in this model, we're assuming is clear by one of those pathways. Okay. So the clearance, we're going to define it as that volume of plasma. Because the drug, the liver and the kidney, they're clearing drug from the plasma. They can't go reach in the lung and get drug out of the lung and clear it. That drug got to come by way of the bloodstream through that liver or kidney for it to get eliminated from the body. Does that make sense? Yeah. So that volume of plasma is cleared of the drug per unit time. Sometimes drug clearances are expressed as clearance of the whole blood, But like I say, the drug might not even be in the erythrocytes and that kind of stuff. So normally, drug clearance is based on plasma clearance. So that's why, instead of total body clearance, sometimes it's referred to as plasma clearance. They mean the same thing to us. Does that make sense? All right. So let me see if I can do my little hammer act, my 2 legit to quit, and see what happens. For clearance, okay. So let's imagine that we have drug in the body. This is the body, and I'm gonna see if this is gonna work. I'm gonna say 1, 2, 3, 4. So I'm gonna split it up into these 4 different volumes. Now we know that the blood system and the plasma is not split up like this, okay? But for understanding, demonstration purposes, or whatever the case may be, I'm gonna assume this is the bloodstream or the plasma, and let's just say, I'm gonna keep this simple, because like I said, I don't know how this is gonna work. Let's just say we got drug molecules in each one of those sections. So if it could actually be split up into sections, you would have the same concentration of drug in each section. That's why I'm just doing 4, okay? So those little dots represent the drug molecules in the body, in the plasma. In the plasma. Are we together? Let's just say over the course of 1 hour, because remember now, the drug is going to be being eliminated, right? So let's just say, and I just chose 1 hour out of the blood, out of the blue, out of the sky. I could have said 2 hours, 3 hours. But since I want to represent it as so many liters per hour, let's just say, 1 hour. Let's say that each one of these little compartments here is 1 liter. So what's my total volume right here? V.
4 liters.
4. If each one of these little segments was 1 liter, yeah, I'll be looking at a volume of 4 liters or whatever it can be. So let's just say after 1 hour, the drug is being eliminated by, KEL. Let's just do it this way. What did I do? Oh. Let's put the KEL over here also. Let's put the KEL right there. Okay. At least a representation so you can relate it to this model here. In 1 hour, let's just say that this happens right here. I'm gonna see if I can draw something similar to the same size. That's close enough. 1, 2, 3. So let's just say in 1 hour, since now I've eliminated some drug, let's just say it looks like this now. Put 2 in there, put 2 in there. What do you got? I mean, in other words, I got rid of half of what was there. Those dots again are like the drug molecules, okay? So, again, we assume that each one of those little blocks is 1 liter. I could say each one of them is 3 liters or 5 liters, but I'm just trying to make the discussion simple, okay? So each one of these little blocks is 1 liter. Okay. Couldn't I represent this as the same thing? I'm gonna put an equal sign there. Couldn't I represent that as the same thing as, let me see if I can draw something close to size again. They're not all exactly the same size, but I didn't do well in 2nd grade art, okay? Couldn't I represent this as the same thing as, now it's not happening like this in the body, but I'm trying to demonstrate a point. So I got 8 here, I got 8 here. Okay. So that means that, and I'm gonna stop right here before I embarrass myself. I think it's going pretty good so far. That means that over that 1 hour period, I've cleared 2 liters of drugs. So the clearance here, I'm just gonna say clearance total will equal 2 liters per hour. Now, in the real body, we're not gonna find any, until all of the drug is gone, we're not gonna find any segments of the plasma that don't have any drug in. I'm just trying to show you a representation. You know, after 1 hour, it would look like this. But in terms of representing clearance, okay, then here we've actually, cleared 2 of those liters of the drug. So that's what I'm trying to get here. So if somebody tell you the clearance is equal to 2 liters per hour or 5 liters per hour, I don't want you to think that in an hour's time, we can go and we can find 5 liters of plasma that don't have any drug in it. That ain't the point here, okay? But it looks as if, if I express the way it would look more like this without the separate compartment, the separate segments. Okay? But I can re-express that as this right here. So it looks as I cleared, 2 liters. 2 liters cleared. So in this case, I would say, well, hey, the clearance here is, the total clearance is 2 liters per hour. But I'm not gonna find 2 liters of drug in the, 2 liters of volume in the body that don't have any drug in it. It just looks like I cleared the equivalent of 2 liters. That's kind of the idea. I'm gonna stop right there, like I said before I put my foot in my mouth. We good? Yeah. That's clearance or whatever. And that's kind of what's going on. This is an equal sign, so we just re-showing this as this right here to show that, hey, it looks as if 2 liters have been cleared. Volume over time. We okay with that? You can funk with that. I did say funk. All right. I'm not gonna get as far as I wanted to today, but that's okay. As long as we understand, that's what's important. Okay, so that's clearance. Now another way of estimating clearance. Remember clearance total. So we can go with V times KEL as clearance. Another way of estimating clearance, this method right here, V times KEL, remember a few days ago, and time is flying so fast, when we talked about pharmacokinetic model, and I told you there's a type of model independent calculation, and we talked a little bit about model independent, and I told you that with model independent system, that you don't have to assume, compartments and all that kind of stuff. And I said that we would use model independent calculation on a limited basis. Well, here's really the essence of the limited basis. Not only can we calculate clearance this way, we can also calculate clearance. This is clearance, but clearance total or plasma clearance is also equal to the dose. That's A0 in this model here. The amount at time 0 that I'm putting in by IV bolus. Dose divided by the area under the curve from 0 to infinity. Now, we haven't talked about area under the curve from 0 to infinity. And depending on what time Dr. Boone shows up at that door, she is. Dr. Boone, go away. Okay, if we don't get a chance to cover it all day, we'll finish it up, either in lab next week or in class on Tuesday. Okay? No big deal. So check out sports. So this is a dose. This is the same thing as A0 divided by the area under the curve from 0 to infinity.
0 to infinity.
0, superscript 0 to infinity. The area under the curve from 0 to infinity. Remember those plasma, like the plasma concentration time curve that we did problem number 2 in laboratory this past week? The area under the curve from 0 to infinity is actually, if we're looking at concentration versus time, it's actually the area under this curve from 0 to infinity. So the area under the curve, so not on top of those points, but all of this area, beneath. I'm just draw a line and then I'll redraw this, okay? It's a bad line, I'll put the X on the line for us, okay? So all of this area here, from 0 times 0 on the X-axis, on the Y-axis on similar paper, you ain't gonna have a 0. All the way out to infinity, so we'll call this our area, we'll call this value out here infinity. So all of the area under that curve, under the plasma concentration time curve, the area under that curve is what this AUNC from time 0 all the way out to infinity. For our purposes, for a first order process, infinity is going to be 5, I've told you, 5 half-lives or longer. Well, after 5 half-lives, we do know that from our laboratory assignment, we know that it took a certain amount of time to eliminate 99.9%, but that's okay. In 5 half-lives for a first order process, we've eliminated more than 95% of what we started with. So for our purposes, infinity is going to, for any first order process, 5 half-lives or longer, you've eliminated essentially all the drug. The reason is because when we look at this equation, C is equal to C0 times E to the power negative KL times T, we do know from laboratory that no matter, you can put 50 million years in here for T, you're gonna still have small values of C. So theoretically C, or the amount ain't gonna never go to 0 mathematically. So we gotta have a cutoff point. So for first order processes, that cutoff point for us is 5 half-lives. So if the half-life of a drug is 3 hours, after 15 hours of young, we can consider that this is all gone. There ain't no C left. But if you put some numbers in there, you see you still have a small amount remaining or small. You follow what I'm saying? So we have to have a cutoff point. For first order processes, it's 5 half-lives. If the drug has a half-life of 1 hour and 5 half-lives, 5 hours, we can say, oh, that drug is gone. But if we put it in that equation right here, or the logarithmic equation, we see that now that's still a concentration. But usually after 5 half-lives, in a real person, that concentration that's remaining or amount is going to be so low, it's not going to have any therapeutic effect. So we consider that it's all gone. So infinity in this model, in this situation is going to be, anytime at 5 half-lives or longer. Okay. The researcher or the investigator had to have a time, I'm just going to stop taking samples. The drug has a half-life of 2 days. We might not want to be sampling drug for, beyond 10 days. Because in 10 days, if the drug has a half-life of 2 days, like the Johnson, half-life of about 2 days, it's going to take, approximately 10 days to get one single dose of the Johnson out of the body. But even after 10 days, some of it's gonna still be level according to this equation right here. It's just that it's gonna be so low, we can generally ignore that. So that's the idea here. So, okay, I got 5 minutes. I might need to wrap this up. If I don't, remind me in maybe lab next week. Don't forget, as of right now, we shoot for Tuesday at 1 o'clock. A gangbang session for laboratory next week. Well, maybe that wasn't the right. Maybe that wasn't the right. That wasn't the best term. A banged up session. How about that? Yeah. Erase that off your records. I need that wasn't cool. A banged up session. Okay, check up on. Let me do this, and then we'll end. And then if I need to continue next week, check out Sports Friends. I need you. I need all of you. Not all of you collectively, I mean, but individually, I need your body, mind, soul, the whole thing right now. So let's go back to the way we had it initially, okay? So the area under this curve, okay, to get the area under the curve for this model, I can do a couple of things. The area under the curve from 0 to infinity. If I wanted mathematics, oh, by the way, this is model dependent. This is a model independent calculation of clearance. Model dependent. And then this is a model independent calculation of clearance. Model independent. Now, like I was telling you, this week has flown by so fast, but I guess earlier this week, with this method, those divided by area in the curve, we don't have to assume that it's a 1 compartment, a 2 compartment, a 3 compartment. This method will work for any type of model. That's why it's called model independent. Sometimes the clinician or the investigator might not want to know whether it's a 1 compartment model, 2 compartment model. They just want to know what the clearance is so they can calculate that patient's drug regimen. How much drug that patient's going to be taking and how often they're going to be taking. They ain't worried about whether it's 1 compartment, 2 compartment, 3 compartment. That's why it's model independent. This method only works for the 1 compartment model sports method. That's why it's model dependent. This ain't this. When we get to the 2 compartment model, or we talk about drug absorption, you know, when we deal with oral drug, this equation ain't gonna work for us. Okay? This equation still will with a slight modification. Okay? Model dependent, model independent. So we calculate the area in the curve this way as C0 divided by KL, or we can get the area in the curve by using the trapezoidal formula, A from 0 to infinity. So we can do it this way, or we can do it by the trapezoidal method. And I'm gonna stop right here and then remind me on Tuesday when we meet again to start with the trapezoid method. Okay. But let me just say quickly before Dr. Poon throws the method of trapezoids. You know that the trapezoid is something that looks like kind of like that. It's got a height 2, and it's got a width. So basically all we're gonna do is divide this curve up into a series of trapezoids. Okay? And put a hat on each one of the trapezoids. Everybody see what's going on? So if we take the area of each one of these trapezoids, we can't forget C0, but we know how to get C0 also. Okay? So if we take each one of those trapezoids, if we add them all together, and I'll continue this next week, like I said, okay? Then if I want the area from time 0, we'll call this last concentration over here Cx, and we'll call that corresponding time Tx. I'm gonna stop right here. First of all, can't you see that the area under the curve from 0 to whatever this time is, it was 15 hours, 25, the area under the curve from 0 to Tx, all I need to do is calculate the area of all these 1, 2, 3, 4, 5 trapezoids. That will give me that area, right? Right? Let's call this T1, T2, T3, T4, and then the last time is Tx. We'll call this C1, C2, C3, C4, and the last concentration is Cx. You got to have a final concentration. So the area from 0 to Tx all I need to do is take the area of this trapezoid plus this one, plus this one, plus this one, plus 5 trapezoids. That will give me the area from time 0 to tx. Conceptually, do you see that? I'm going to give you the math, again, for calculating the area for a trapezoid. But we can calculate the area for each one of these trapezoids. This is a case where you do connect the dots, by the way. You know, you connect C1 to C2, C2, because all of these might not be on a straight line. So this is a case where you do connect the dots, okay? So if I add those 5 up, then I can get the area from 0 to tx, and then we got something from tx on out to infinity. Remember we said infinity? So this area out here is called the residual area from tx to infinity. Because we still got some area left under the curve, because if cx is not 0 yet, we got to consider the rest of the area. So that's so-called residual area. Yes. I'm finishing up that one. I apologize. The residual area, and the residual area is just equal to C, whatever that final concentration here is, divided by KEL. That's the residual area. So, and I'm going to end up right here, that if I add these 5 trapezoids together, and remind me to start on this the next time we meet, plus the residual area, then the total area under the curve, from 0 to infinity, is equal to the area under the curve from 0 to tx plus the residual area. And let's just call it quits right there, residual area. That would be the total area in the curve. The area in the curve from here to here plus the residual area. That would give you the whole shebang.
And you said residual area is TX over K?
It's written on the board. Come on.
T
Don't.
or C?
Yep.
That's T, okay.
Okay, I'm sorry. Yeah, that's CX. That's the last concentration, yes. Divided by KEL, which we know how to calculate KEL. Thanks, how to do it. I apologize. What's that, the fire? Smoke detector?
The battery died.
We need a battery.
Ah, well, that's distracting. We good?
One quick question. It's, by definition, what is KEL?
What is KEL?
Yeah, by definition.
Come by my office with us. First order rate constant for elimination in this moment. By definition. First order rate constant.
Usually like the K.
We good? Okay, so you all have a super weekend. Be safe. Take care of yourself. You guys.